Thank you, everybody, for being here today. I'm very fortunate to be working with an amazing group of people and advocates around the world. My journey for health equity started more than a quarter century ago. Health equity word was starting to make its way into our health advocacy language, and I was heading a small health center in an urban slum area. One day, after hours of waiting for her turn, a woman in tattered clothes carrying a naked child walked into my outpatient. I thoroughly examined her, handed over the prescription. She looked at me strangely and said, "Where is the medicine?" And I said, she could take my prescription to the chemist shop and she can get the medicine, and that would make her healthy, or that would help her complain. She looked at me. That's a look that I can remember like yesterday. If I close my eyes, I can remember her face, her child, her tone of voice. She tore my prescription, threw at me and said, "What good is this if you do not have medicine for me?" Yes, what good is a well-written prescription if she could not buy the medicine? Health equity is not about one or the other piece of healthcare delivery. It is about removing all the obstacle in the way of health. No matter what I did, no matter what job I took, and no matter where I live, I think of that woman and child and so many millions who do not have access to fundamental right, health. Health equity is about social justice. You know, COVID is at the top of our mind, of course, rightly so. Health disparities existed before COVID-19. COVID has further exposed and increased them. They existed, the health disparities, they existed between countries, they existed within countries. Let me take you to my own experience on that. I grew up in India with socio-political privilege. Advocating for rights is in my DNA. And being a physician and with time being engaged with human rights movement, health rights became focus for me over years. When I moved to US almost 2 decades ago, I did not have health insurance for some time. I hurt my foot very badly. It was small, swollen like a watermelon, maybe a cantaloupe. But anyway, I ended up doing home treating my foot. And it would not cross my mind that I would not have access to a doctor when I was living in India. For the first time, I felt what health inequities are in a way that I had not felt before. I felt them. I felt them first person. And it's different. Let me tell you, it's very different as an advocate when we are advocating for others. And when we put ourselves in that situation, and it's a circle. We could end up on the other side at any time. You know, COVID-19 has pushed so many people who may not have thought they would end up on the other side of the fence, pushed over the edge into poverty, debt, and unable to afford the health care. I bring up this point to share that disparities exist everywhere, in low and middle income countries and in high income countries. Achieving a health for all is a shared goal. It is the right thing to do, and it is in our self-interest as well. Again, COVID has made it even louder and more apparent. These are not new issues. They existed before COVID. Achieving health equity is not going to be easy. It's a multi-generational marathon structured in a relay race. We work our best to our capacity and pass the baton to the next generation, hopefully in a better condition than what we received. We made better time than we had. It's a ring of fire. I look at it as a ring of fire, and we have to go through it to succeed on any health goal. It is difficult, but there's no shortcut. However, we do have a strong, suitable vehicle to get us to our goals: partnerships. Yes, partnerships that are equitable and diverse with the foundation of mutual respect and learning. The partnerships that confront and reject the power dynamic of colonial roots. Equitable partnerships are going to be messy, but that is their strength and not a weakness. You know, I remember an incident when I was organizing all-party, all-religion group in wake of the religious intolerance in India. And it's funny to remember that we did not have much fight on the content of what we are going to advocate, what we are going to, our messages are going to be. We had long discussions, robust opposing discussions on which color of the banner to use. You know, one party had an orange color, the other had blue, one religion had a green color, other had white. So it was so difficult to pick the banner. But believe me, the messiness is its strength. Diversity is its strength. And we came out strong after 6 months of organizing, and 5,000 strong people marched during the pouring rain. I remember that as a learning and as well as very gratifying thing to do. When COVID-19 hit India in recent times, you've heard about how difficult the situation was in India. The Indian diaspora came together in a loosely structured group with a common goal to help the people in the country we come from. A very diverse group of people, scientists, physicians, researchers, journalists, and some policy folks like me who intersect some of them, some of those areas. And it is amazing how the language of each one of us is different. But common thread made us communicate through those barriers. It was messy, it was difficult, we are still sorting through it. Every night we will have calls with people on the front line. The families, the doctors, the journalists, the officials, professional associations will show up. They will share with us what's going on and what's needed. And we will listen. The group will listen, form small groups. And then we will try to address as much as we could. Organically, the group expanded to include people from neighboring countries, Bangladesh and Nepal, as the COVID hits the neighboring countries. The informal advocacy channels were forced at the regional and global levels, pushing for oxygen availability, medical and other technical support, vaccines. Some successes, but a long way to go. The devastation left by COVID will be felt for a long time. We all know that. The gains made towards health have receded by decades. We have a lot of work to do. More than ever, solidarity is needed among the global community to address the ongoing pandemic and also to repair and build at all levels. As Joanne mentioned before, Action Global Health Advocacy Partnership has leveraged the diverse strengths of its 15 global partners to achieve very impressive successes at the regional and global level. Among many uniquenesses of this partner is the multi-directional sharing and collaboration. Information, knowledge, strategies, we share that go from north to south, south to north, and everywhere possible. So my colleague, Rosemary, will share her experiences and some examples of collaborating at the regional and global level to achieve results. Rosemary Mburu is the Executive Director of Waki Health. She has over 12 years of international experience in areas of public health research, programming, and advocacy. Rosemary is a civil society organizer who has extensively worked on building and strengthening civil society networks and platforms in health-related advocacy and campaigning in Africa. Her current role involves policy analysis, advocacy, and civil society organizing towards a united African civil society voice and action to influence political decision towards ending AIDS, among other life-threatening epidemics, and improving health for all in Africa. Rosemary holds a master's in public health from Ohio University, a master's in business administration from Fortsburg University, State University, Maryland, and a bachelor of education from Kenyatta University, Kenya. And I'm so, so honored to be learning and working closely with Rosemary as one of the amazing executive directors in our partnership. Rosemary, over to you.
Thank you very much, Vineeta. It is always a pleasure to join the Results International Conference. There's a lot of inspiration and a reminder of why we do the work we do. For me, this moment reminds me of where we are coming from, especially for our region. COVID-19 has some similarities with the HIV epidemic, and my background coming into this advocacy work is mainly informed by experience in the HIV response in the region, in Africa. One of the things that COVID-19 has demonstrated that reminds me of the HIV epidemic is the fact that it's reminding us of the challenge of inclusion. Low and middle income countries being left behind in terms of access to vaccines, access to therapeutics, and access to diagnostics. It is a reminder of where we are coming from. Many years ago in terms of the response to HIV. Even now with COVID-19, we are seeing the same. It is also a reminder of the inequities that COVID-19 is exposing. They already existed, but also COVID-19 is feeding off those, and also it is actually increasing those inequalities. We are seeing millions of people being pushed into poverty, especially the most vulnerable, including women and girls. There is a gender dynamic with COVID-19 and with the work we do, especially around nutrition, education, health, social protection, with women and girls being disproportionately affected. And that is so even for our region here in Africa, and I think especially for our region. One of the things we saw with COVID-19 in our region, and I would think it is the same for all the low and middle income countries, is that when our countries went into lockdowns and schools closed, that disrupted a lot of things, including feeding programs. And that is where the issue of social protection became a challenge, the issue of access to meals became a challenge, and the issue of nutrition became a challenge as well. Issues around sexual and reproductive health became a challenge, et cetera, et cetera. We saw service disruption from maternal health care to access to routine immunization, access to TB, screening, treatment, et cetera, et cetera. Everything was disrupted. And so in terms of inequities, there is a great need for us to move the conversation of pandemic response, pandemic preparedness from just a global health security conversation to a conversation of global solidarity and global health equity. In Africa, we do know that, like in the whole of the world, there has been an economic contraction, but more so in low and middle income countries. In Africa, for example, we've had about a 20% economic contraction in 2020. And so our governments saw a decrease in revenue. And that meant that for them to respond to COVID-19, they had to borrow resources. And that has actually increased our debt to GDP ratio. So when we think about that and we think about rebuilding, we think about responding, it comes at a time when there are so many inequalities, there's an economic contraction, there are already existing challenges within the region, whether it's on the other epidemics, HIV, TB, malaria, and high maternal mortality ratios, high rates around stunting among children, et cetera, et cetera. So as a partnership, some of the things that we've been doing as action partners in our region include advocacy around domestic resource mobilization. We are very keen to ensure that there is country ownership and country leadership. A lot of the programs that run in many of our countries are funded through external partners like the Global Fund, Gavi, the Global Financing Facility, and many others. And those are important. Those are very important. And thank you very much to all the results, grassroots advocates who make it happen, with the US giving and pledging to all the different global health institutions. Thank you, thank you, thank you. But we also know that it is important that our countries are also coming to the table and putting something in terms of domestic resources. It helps in country ownership. It helps in country leadership, and that's something we are working on. We're also working on the issue around better data and accountability, making sure that we, as civil society, as action partners, we have the tools to ensure value for money, to ensure results and impact. We are also working around equitable access to vaccines, therapeutics, and diagnostics. The African Union is taking very seriously the issue around local manufacturing. One of the things that we are very keen to seeing develop as a region is the fact that we shouldn't wait for another pandemic for us to be at the bottom of the queue when it comes to accessing those products. And so there's a big conversation here. How can we start with baby steps to ask ourselves, what does it take for Africa to begin the journey around local manufacturing? And as we do that, we are also very much pushing around intellectual property rights and flexibilities to allow the breakthroughs, the scientific breakthroughs around COVID-19 tools to be accessible, transfer of technology, transfer of knowledge, so that we could have them produced in more affordable prices and generic accessibility, et cetera, et cetera. We are very much thinking about the Africa human capital, ensuring that investments in Africa are directed towards ensuring that Africa's population can develop to the highest possible potential. With this, as action partners, we are engaging with the World Bank. We are engaging with IDA 20 to remind the bank that the Africa human capital needs to continue to be prioritized. This is a commitment that the bank has to ensure that the commitments around investing in capital investments such as education, nutrition, social protection are prioritized. We are very keen to see that primary health care is prioritized in all spheres of global health, investment and planning and prioritization. Our message has been that primary health needs to be at the center of pandemic preparedness and response. Many of the deaths we are seeing are preventable. They are either preventable through vaccination, they are preventable through screening and identification of cases, whether, for example, in TB, et cetera, et cetera. And so as we move forward, especially within the Africa region, Action Africa Partners has really been emphasizing on the need to ensure that primary healthcare is the main lens that we work with towards achieving equity. And last, Vineeta, just to mention the work that we are also doing at the Access to COVID-19 accelerator space. We are supporting the civil society and community reps together with partners such as the Global Fund Advocates Network and Stoppage to ensure that there is a robust civil society constituency of the ACT in terms of ensuring that there is accountability and that the investments there actually trickle down to results and impact to the most vulnerable. I thank you very much and look forward to having this conversation.
Thank you, Rosemary. Thank you so much, as always. We will take a couple of questions from the audience. And one question that came from Beth is, why are women and girls disproportionately impacted by COVID-19? And I'll just throw in some things that come to my mind, and Rosemary then would love to hear your thoughts on it. So why is, it's a deep question, and we discussed in the previous session as well. And I'm thinking, what can we do moving forward so that women are not disproportionately impacted? And if they are, then the issues are addressed, not only to remove that disproportionate impact, but also address it. So for me, as a human rights activist, I feel like gender is at the soul of everything we do, right? Whether if we are not collecting the data of how it is impacting gender and women in this case, and how are we going to determine what is affecting it, and how are we going to allocate resources? So we need a data collection. We need a resource allocation specifically to address those. And then in implementation, we need to see that those communities that are affected, and in this case, women, and they need to be part of the solution and implementation. So I want to share a quick example on the COVID work that we are doing with Indian community is, one person shared the story. They said, okay, the vaccine is when even it's available, women are not able to go out and get it because they're cooking, they're not able to isolate themselves, they're cooking, they don't have time. Everybody else priority takes the precedent in the family. So what are some of the things that we can do at the advocacy level, at whether it's in country or global or regional level? I know it's a huge discussion, Rosemary, in itself, but any quick ideas that you can share?
I think, Vineeta, for me, one of the things that comes to mind is the global solidarity, especially among civil society. We know our countries and heads of governments need to work together, but also I think as partners, for example, the way the action partnership is structured with partners in low and middle income countries and with partners in high income countries, I think it's a really good model of how partners can work together to leverage the strengths of each space. So being able to be close to the data, access the evidence in high burden countries, but also be able to engage with high income country leaders who can actually invest in these issues through the different global health financing mechanism. I think it's a strategic partnership, and I think the way to go in terms of unlocking some of the potential funding that exists, but also being sure that we are involving and engaging the most vulnerable, and that advocacy is actually coming from the grassroots level. That's my quick reflection on that.
Yeah, thank you, Rosemary. Sometimes the complex issues, it's so difficult to come up with a couple of things to share. This is a conversation that we'll take on and keep carrying in our work sphere. And also, please, everybody, engage with us on this and other issues or other thoughts that you have through social media at results_tweets and action_tweets. And Rosemary and my Twitter handle are also available. Throw your questions and thoughts our way. Thank you for all of you for sharing your precious time with us today, and thank you. And there is an hour-long break now, and the conference programming will resume at noon ET. We'll see you in an hour. And again, thank you.